today we mark the World Malaria Day, and I'm joined here by researchers from KEMRI Wellcome Trust in Kilifi. On my far right is Dr. Francis Ndongo. Next to him is Dr. Patricia Njuguna, Professor Philip John, and just next to me is Melissa Kapulu. And the WHO just released a few facts here, and they're saying that malaria has gone down, reduction in malaria deaths have gone down globally at 29%, and the malaria cases have also gone down by 21%. But I want us to get the general picture of where we are as a county, as Kenya, and as Africa, and we hope that it's going to be informational for you. I'm going to start with Professor Philip John, who is going to give us a general picture of how malaria looks like at the moment.
Okay, so you mentioned where we are in Kilifi.
Yes.
So in Kilifi, we've got a lot of very detailed data about what's happened to malaria over the last 27 years. And we know that malaria has definitely come down very dramatically, hitting a low point at around 2009 from very high transmission in the early 2000s. We've got that data here because of investment in monitoring through the hospital and through peripheral facilities. In Kenya as a whole, we've got less detailed data. I mean, several other research institutions have contributed to data on malaria within Kenya, but we're less clear about what's happening, for instance, in the northeast or in the north of Kenya in terms of malaria. If you zoom out now on East Africa, you know, data in countries like Uganda and to some extent Tanzania and certainly in Somalia becomes much more sparse. And now if you zoom out to think about the whole of Africa, there are countries where we have very little data. So I think it is really very encouraging that there are reductions in the malaria deaths and the malaria cases being reported, but we should bear in mind that our data are very incomplete and that at the moment we're having to combine incomplete reporting and also predictive models to try and fill in the gaps between data.
You alluded to the fact that we've had a few intervention strategies that
Yep.
have made malaria. And I want Patricia to sort of talk about from a clinical perspective how some of these strategies, how we normally implement them in the hospital.
So the Kenyan government has in place several malaria control strategies, and this start from the women in pregnancy. We also have within all the health facilities, we have a test and treat approach. So all the health facilities have been provided with rapid malaria tests and the access to the new available antimalarials, the AL, but also distribution of bed nets across the country to provide prevention for malaria. And in specific hotspots, they do also provide additional spraying for malaria control. So all these are currently in play. But also we are still doing research, looking at other interventions, looking at new drugs and the possibility of vaccines for malaria.
Come back to the vaccine story, and I want to bring in, talk about other strategies and some of them which have been done in the lab. And Francis, would you please tell us where we are in terms of immunological work around malaria?
Oh, thank you. So we obviously have invested a lot of money and effort to develop a malaria vaccine. And in order to develop a malaria vaccine, then of course we need to conduct these immunology studies that will give us the knowledge that we need to be able to develop that vaccine. And so far, as you know, and as has been reported, we have had one vaccine that has been tested here in Kilifi and in other parts of Africa. RTSS it's called. But the results that we have so far shows that this vaccine is only partially effective. And of course there has been many others that have not reached the stage where RTSS is, RTSS being the most advanced vaccine. And so many others have been tried but have not even reached the field.
And what is still ongoing.
And what I suggest is that we are quite far away from making a product that is going to be highly effective. And so the work that we are conducting here in the lab is to try and understand how naturally acquired immunity works. Because we know it happens. If a child born in an area with a lot of malaria, by the time you're 5 years old, you are resistant to clinical malaria.
And we're going to talk more about that, but I want to quickly shift to Melissa, who is an in-betweener between the lab work and entomological work. And we've just talked about vector control. And just give us also your perspectives about that and the reducing numbers in terms of mortality and malaria cases.
Well, I think in addition to what everybody has said, and following on from what Patricia has mentioned, there are a number of interventions that are targeting the mosquito. And the reason being is that if you reduce the numbers of mosquitoes that spread malaria, you eventually reduce transmission to human beings. But on the upside to that is you also need to reduce the ability for human beings to transmit malaria to mosquitoes, and therefore there is need for targeted interventions for that. Both insecticide-treated bed nets that everybody has talked about are helping to reduce numbers of mosquitoes that are possibly infective. But of course you have the case of, like in the case of drugs, you get resistance to insecticides, and that is now spreading. We see insecticide resistance mosquitoes that are that the insecticides are no longer effective. So there is need for new interventions that are able to both control malaria within the mosquito population as well as control malaria within the human population so that you can reduce transmission.
You mentioned about insecticide-treated nets. Philip, can you tell us where we are in terms of coverage?
Yes, so there's no doubt. Coverage of bed nets has really dramatically increased over the last decade or so. We're now in a situation where many of the counties with highest risk of malaria have got bed net coverage, 70, 80%. And actually it's worth reflecting on that, because 10 years ago, people would have seriously doubted that was going to be possible. And it's happened as a result of commitment from donors, and it's happened because of national systems being strong enough to achieve delivery of those nets. We know that if a child uses a bed net, their risk of dying from malaria is lowered, and we know that their risk of ending up in hospital sick with malaria and their risk of needing to take medication given to them from a dispensary because of a fever, all of those risks go down because of the use of bed nets. Something slightly puzzling, though, about the rollout of bed nets that we see in Kilifi is that actually we can see malaria was going down quite rapidly even before bed nets were scaled up. So I think that there's no doubt that bed nets are a very important strategy, and hundreds of thousands of lives have been saved across Africa in the last few years because of bed nets. There's no doubt about that. But there are also other things that are driving trends in malaria transmission that are not related to the things that we're doing.
And we'll come back to that. And I just want to shift focus on the vaccine story. And we've done, you mentioned, Francis has mentioned RTSS. And I know we had quite a bit of input on that. And that's what I want Patricia to unpack for us.
So we were involved in both the phase 2 and the phase 3 parts of testing the RTSS vaccine. And the phase 2, we were able to show protection up to 55% at 8 months of clinical malaria episodes. And that led to the decision to go ahead to a phase 3 study, which was conducted in 7 African countries with 11 sites involving over 10,000 children, both infants and older children involved in the study. The results of that study showed that in infants, the vaccine seemed to be less effective in controlling malaria cases than in older children. And in older children, when we looked at long-term follow-up, there was protection up to about 30% at 3 years. So based on this data, the WHO has reviewed the data. Both EMA and WHO have reviewed the data and opted to go on to do pilot implementation. So meaning they want to see a real-world effectiveness of the vaccine in populations where there is moderate to high-risk transmission. And that is the next phase of the trials.
And is RTSS the closest we are to a vaccine?
It is the most advanced vaccine in development. There are other vaccines in development. So there is Sanaria is involved in looking at sporozoid vaccines, and there are other vaccines in the pipeline. But that is the vaccine that has come the farthest and is the closest to licensure currently.
Melissa, I want us to talk about your recent study and how that will feed into the bigger story of getting another vaccine.
So the work that we're currently doing is trying to understand, like Francis is working on, immunity to malaria.
Mm-hmm.
As Francis has said, that naturally individuals do acquire the ability to be resistant to parasite infection, and not only parasite infection but also clinical case. So what we've set out to do is to have individuals with varying exposure to malaria. So individuals who have either had little or no malaria experience, and individuals who have recent exposure or who have had historic exposure to malaria. And if we gave them another case of, if we gave them malaria, how would they respond to that particular infection? Would they be able to resist? Would they be susceptible to clinical malaria? Or would they be able to control parasitemia? And we can then relate that results that we get to their past exposure. And that will help us more or less to also come up with targets that are potentially involved in resistance or susceptibility to malaria.
I think the ultimate question that is going on in people's mind is, why is that difficult to get a vaccine of malaria, just like all the other vaccines that we normally have? And I want Francis to sort of break down that for us.
The parasite that causes malaria is quite complicated, has a complicated life cycle, that has to go through the human host and the mosquito. And within the human host also there are different stages, and each of these stages will make its own proteins. And proteins are, of course, the ingredients that we use for making vaccines. And also these proteins are very complicated, so it becomes quite difficult to know which one to pick and turn it into a vaccine. And the other complication is that because the host is having to deal with so many different proteins, it is estimated to be about 5,000. This also, I suppose, kind of confuses things. I mean, when we look at the immune response to malaria in humans, it takes quite a long time for people to develop protective antibodies.
Yeah.
And so it's been quite difficult to understand, first of all, which protein, which mechanism, contributes to the protection. But we are learning a lot, and of course, the work we're doing here at KEMRI Wellcome Trust is to try and find which antigens or which proteins can induce immune protection, and then once we identify them, then we work out what the mechanism is, and that can inform vaccine development.
Yeah. Just before we went for a break, Melissa was telling us about the study that KEMRI Wellcome Trust is taking, the controlled human malaria infection. And I'm wondering, is it even safe to give people malaria?
It is safe. Studies are known to be safe. The number of parasites that we give you in the studies are much less than we'd expect that you would receive should you receive a mosquito bite, and people get malaria every day. The other things that we have in place is that the study has been reviewed by various ethical committees and made sure that safety of the participant is enrolled. We have clinicians who are with the participants at all times after infection, and we follow them quite closely every day until they get malaria, and we treat them at very low levels of parasites in the blood. So thus far, in the various controlled human malaria challenge infections that have been conducted both in Kenya and in other areas, nobody has had a poor outcome, or has it been shown to be unsafe. And so we are confident that this is, as we said, it's a controlled experiment, and so no person's life is at risk.
And I want Melissa now to tell us, why is this study even important?
The reason why we're trying to understand what happens with human malaria and why we're trying to give individuals malaria is that it's very hard to replicate what you see in a human being with any other animal model. And therefore what we're trying to do is we're trying to come very close to actually what happens in nature. So if you gave somebody malaria, how would their response to that particular malaria insult would be? So hence the reason why we're doing this controlled human malaria infections. So the main reason is that we really want to come down to the nitty-gritty of things. If an individual who has had previous exposure has had some naturally acquired immunity, what is that naturally acquired immunity that allows them to actually not succumb to infection? And then if there are individuals who have not been exposed, what is it about those individuals that enables the parasite to ensure that they come down with an infection? And that is why we're trying to carry out these controlled experiments to understand naturally acquired immunity, to also come up with targets that could be potential vaccine candidates that could be developed as malaria vaccines. And then another thing is we also need to understand individuals in an individual setting. Of course, human beings respond to things differently because we're all made differently. So is there specific things about those individuals that make them susceptible or resistant to malaria?
It's like a big study, Philip. It might have a bit of an impact in the whole journey to vaccine development. How long is it going to take?
We're going to spend another 2 years completing this phase of the study, giving people malaria and studying the outcomes. I think, though, that the resource we build up in terms of the data on what has happened to people in terms of the parasite growth and the use of the samples from those individuals to look for new and refined immune responses that will lead to greater and greater degrees of immunity when used in a vaccine. I think that resource is going to be exploited for a decade or more. Because I think there's a lot of progress to be made, and B, because I think getting a malaria vaccine is just so very important.
Are you the only ones who are doing it in the world?
We are the only people who are at the moment doing it in these sort of numbers in Africa to study immunity to malaria. The study of, the process of giving people malaria has been done very widely in Europe, in Australia and in the US. It's normally done in people who actually don't have any immunity to malaria, and it's done to test a vaccine. So the group being injected with malaria are divided into half. Half of them have had the vaccine, half of them haven't. And it's a very quick way of getting an indication of whether a vaccine has potential before it comes to the field. So I think we're the first group to be doing it at this sort of scale in Africa in order to study immunity acquired by people living in Africa exposed to malaria.
I want us to wrap up this conversation, but we've heard so much about the challenge study. Is there anything else that is happening?
Yes,
to understand the malaria immunity more?
Yes, we, apart from the studies where we're infecting people with malaria and then studying the immune response to that malaria, we have other studies that are going on. And a good example is our study where we are using systems immunology approach to understanding malaria immunity. And without being bogged down with the complex terminology, what it boils down to is to the fact that we, from our analysis of malaria cases in Kilifi, we have found that there is a group of children that continues experiencing excess amounts of malaria while their age-matched counterparts are already immune. And so these are children with increased susceptibility to malaria. So we are trying to understand the factors that leads to these children being more susceptible to malaria, in spite of the fact that they are the same age with those who have already become resistant and also exposed to the same amount of malaria in the microenvironment. And that study is important because it will, if we know what makes them more susceptible, then more interventions can be directed towards that group.
Are we looking forward to partnering with other people to do more clinical trials in the future?
Yes, I think there is still space to continue doing clinical trials. We are involved in the human malaria challenge studies, but we are also involved in looking for new anti-malarial drugs. We know that resistance towards anti-malarials continues to be a problem, and so that sort of research continues to be important to us. And we'll continue to be interested to test vaccines in the future that could be more effective than RTSS once they come to fruition, but and that's our focus for now.
Philip, the numbers are going down. Are we looking at the next 30 years we're not going to have any malaria in the world?
Yeah, I hope so. But there are two groups of things we need to do actually to ensure that happens. So the first is we need to sustain what is being done at the moment and deal with certain threats. So Patricia's mentioned drug resistance. I mean, drug resistance is evolving at a really rapid rate in areas of Southeast Asia, particularly Cambodia. And if that isn't dealt with and there isn't targeted malaria control before it spreads across the world, then that is going to erode some of the benefits that we've seen recently. Melissa mentioned resistance to insecticides by the mosquitoes. So at the moment, although there is insecticide resistance, it seems that bed nets are still working. I mean, as far as we can tell under field conditions, they're still working. So there's no need to kind of panic now, but eventually we expect that there will be a level of insecticide resistance that means that bed nets don't work anymore. So those threats need to be dealt with. But in addition, we need something extra. I mean, even if we were to prevent insecticide-resistant mosquitoes emerging and present drug-resistant malaria, if we actually want to have no malaria left in 30 years, we do need something else. And that then returns to our very kind of long-term commitment to vaccine development, because we think that that is one of the key interventions for the future that really will drive us towards zero malaria.
Melissa, the mosquito is becoming clever and clever. What are some of the things that are being done to curb this insecticide resistance? So
the alternative approach actually is trying to stop humans spreading malaria to mosquitoes. And that is research around something called transmission blocking vaccines. So these are vaccines that are given to an individual to stop the spread of transmissible parasites to mosquitoes. So that's one intervention to look out for. And another intervention is genetically modified mosquitoes. So these are currently, there are a number of sites that are beginning to test genetically modified mosquitoes to try and curb the mosquito population that's responsible for transmitting malaria. But all these interventions, I think, will in a way add to other interventions. For instance, whether it's going to be a vaccine that will stop blood stage infection, or whether it's a vaccine that will stop infection going into the liver, for instance, the RTSS vaccine. All these in combination, I believe, will, maybe in 30 years' time, we will have no malaria in the world. But of course, there is need for concerted efforts to ensure that these interventions are available for individuals to use in the future.
Thank you very much, guys, for joining me on set today and discussing a few things that I know will interest people around the world about where we are in terms of malaria picture. Thank you very much for joining us.